Freedom HealthWorks is the direct primary care accelerator. We help doctors across the country start fresh in direct primary care. With Freedom HealthWorks, you work with a team, not a checklist. Visit freedomhealthworks.com and together we can achieve true freedom in direct care.
Vineeth, KPI Ninja is blazing a trail in what we're calling the data world, which can be a good thing or can make jobs and lives a little harder when dealing with healthcare. So tell us a little bit about what sets KPI Ninja apart from where we've heard this data word, and I'm using air quotes there, where we've heard this word used in healthcare settings before.
Yeah, Chris. So we believe at KPI Ninja that improving outcomes, at the organization and the patient level is what matters. And using data and analytics, to improve the outcomes that matter to the patients and that matter to the organizations is the key thing, on why organizations are looking at data and using data within their organization. So on how KPI Ninja differentiates ourselves compared to how other analytics companies or how healthcare uses data typically from a vendor perspective is, usually you deploy a technology solution or a product, and it's up to the organization to use the solution. However, from our perspective, we come with the end in mind, understanding what is the organization trying to achieve, what are the goals for the organization, and trying to provide the tech solutions and the necessary support to accelerate the improvement of the outcomes is how we differentiate and how we use data to improve the outcomes that matter to the patients.
So looking at data as a tool to help physicians take better care of their patients, right?
That is correct.
Now, we've talked before about you kind of have a triple aim, and we were just talking about this yesterday, just in a conversation. So what does that mean to your organization when you talk about trying to help people with kind of this triple goal?
Yep. So as the triple aim stands for improving the experience of care, reducing the per capita cost, and improving the population health. So if you look at that, with the DPC lens perspective, there are a number of questions, coming in, from employers, in general, who are looking at, different ways to reduce the overall cost when the premiums are going, up at a double-digit rate. So it is really important to understand, the overall cost impact, not just the DPC membership cost, but the overall cost, maybe at an employer level or maybe at a practice level, the impact that DPCs are making. So again, data becomes an important element to understand, what is the impact that's happening around the cost and in which areas, for example, is the cost being reduced in the emergency room areas, or the specialists are going to be reduced, or is there a reduction, from a utilization / cost on prescriptions or something like that. So it's really important to measure that, identify where the costs are, and see how DPCs can use actually to make an impact on that area. Yeah. And the second category is experience of care. When you talk about experience of care, it includes quality outcomes. It includes how the patients are experiencing the care, and also it includes the access to the physicians, and that's where the virtual communication that is embedded as part of the DPC, and also how the physicians interact with the patients and how long they spend, and how accessible they are when the patients have needs to take care of their problems and stuff. So all of those things, measuring that and comparing that with the fee-for-service space is going to be important to demonstrate the impact of DPC. And the third category is population health, understanding the impact of outcomes, whether you're talking about specific chronic conditions or whether you're talking about the overall impact in improving the health of the population is really necessary. And again, if you look at all of these three different categories, these are the lagging indicators, to understand what is the overall impact. From our perspective, in a data-driven standpoint, you need to identify those leading indicators that would make an impact, so that you can actually see those outcomes improved and overall have an impact on the triple aim itself.
Right,
That's the
right.
view
So,
from a DPC perspective.
Yeah, so not just about lowering cost, but we're really looking at in KPI with this of how we actually help people get healthier there. So, Kyle, I want to ask you this, and like I mentioned earlier, data is a very small word, but has a very large meaning in the terms of there's a lot of confusion behind it. So, why does data usually make physicians and medical personnel a little squeamish?
Good question. I don't know if I would be the right person to ask for that, and just because I'm not a clinician myself. But the experience that I've learned, working in the health system is that, one, they have to spend a lot of time documenting in order to receive data on the back end, and they're hesitant to do that. And they also got burnt quite a number of times on trying to do that and just getting poor data in return, poor value in return.
Right. Right. So it sounds like they were taking a lot of time to document a lot of different things that there was no point. Was there any conclusions that could be drawn from that?
Yeah, and the other thing I would say is they were almost asked to document things that they didn't see as important or providing value to their patient relationship,
right,
and patient healthcare outcomes. So they were, healthcare administrators would come to them and say, "We want you to start documenting these and spend a lot of time there," and you're not getting a lot of value from the physician-patient perspective.
Yeah, and then they're saying, "Well, why do I need to spend more time putting these numbers or these codes into this software system when I should actually be talking to my patient because they might have the answers?"
Yeah.
And also, Chris, as you know, there are a number of studies in the fee-for-service space on how much time is being spent by the physicians, by the providers, by the clinicians, in regards to documentation, and especially with the growing number of quality programs, whether it is coming from CMS or coming from different payers. So that adds quite a bit of burden, and also in the fee-for-service space, where the average, time that the patient actually interacts with the physician could be, in a single-digit number, whether it is 7 minutes or 9 minutes, per patient visit. So it is really important to understand, what is value added, from a patient perspective, and identify, how can we reduce the overall, the non-value added activities, which could, from a patient perspective, could include, the time that is being spent on documentation and all other areas, right? So that's why when physicians, move from fee-for-service, to a direct primary care model, so their main focus is how do I create more value, and how do I reduce any unnecessary activities. And when you look at from that lens, and especially with the exposure they may have, interacting with all these value-based programs, and the amount of documentation and clicking off different, buttons within the EMR to, to qualify for certain measures and stuff. So there is that, initial hesitance in regards to, okay, what am I going to sign up, and what does
right.
data mean, from that perspective. So it is really important, on how we have, constructed on how we operate, understanding the DPC model, to demonstrate the, the impact specifically for DPC. But from our interaction with physicians, that's the sense that we get, when we talk about data to begin with, for some of them.
Right, right. And I appreciate you saying that too, that, we addressed the concern of, like Kyle said, a lot of this stuff was just, it's unusable or unnecessary, but to take it into the DPC world, because you work with a couple different, what I'm going to call customer bases. You have the health information exchanges, and then you have the direct care world where you're really making a big splash, and KPI Ninja has kind of become the go-to person for direct care information and data. But this whole theme that data can be your friend, and really is your friend, but it has to be done correctly. So on that theme, what is the right way that you're seeing direct care practices? Because we'll focus on direct care right now. What's the correct way or the right way that you're seeing direct care practices implement data plans and then use it?
Sure. So in my experience, the phrase that we use in public health is an ounce of prevention is worth a pound of cure. And so in DPC, there's a couple ways that you do that. One, better access and better quality of care, more time spent on preventative measures instead of reactive, which in some leads to better patient satisfaction, and then it also leads to better patient outcomes, which leads to lower downstream utilization, which leads to lower cost overall.
Mm-hmm.
So using data to measure each one of those pieces, we're seeing better access, we're seeing better quality, we're seeing better outcomes, we're seeing lower downstream utilization and lower downstream costs. And there's data components to each one of those pieces.
Gotcha. Yeah, that all sounds amazing. It really does. Being able to show somebody that, look, this is effective here, kind of leads me to my next question. And this is something that we at Freedom HealthWorks get a lot, just describing the overall direct primary care movement and just direct care in general, is that some detractors potentially say, show me the data, show me the studies, show me the reports that are published, peer reviewed, all that kind of fun stuff, showing that direct primary care is a healthier option for people and ultimately for physicians. And to my knowledge right now, there is just a massive lack of studies in direct care. I know Freedom HealthWorks, we're driving hard to be able to do that, to be able to publish those type of reports. But what do you guys say to those type of people when they say, show me the studies?
Yeah, I agree. And Chris, side note too, we'd love to help you guys start publishing stuff. That's a goal of ours as well.
Absolutely.
So yeah, I mean, my response to that is absolutely. There's no little to no published evidence that, this model actually works. And the reason being is that collecting, extracting, and analyzing that data is difficult, timely, and costly. So the movement's just not mature enough to have gotten to that point. And you also need to, in order to, have a rigorous study, you need to be able to identify and single out DPC as the main reason why outcomes improved or cost improved. And it's difficult to do just because it's such a fluid market. And, there's 1,200, 1,300 clinics across the country. Each one is uniquely different, practices in different ways, and their sample sizes are just too small. So we're certainly working on that, and it's a critical goal for us to start collaborating on research studies and producing research studies ourselves. But we are probably on the front end of understanding how difficult it is to actually be able to do that.
Right. So what is the best way moving forward? What's the best way to be able to capture those type of data? And I do understand that KPI Ninja, you guys are kind of taking the lead to be able to publish some of those reports and stuff. So talk about a timeline if you have one, or what your vision is to be able to produce something like that.
We're hoping to start having some reports out by the end of this year, and then moving forward on an annual basis at a minimum from there. And some of the steps that we've taken, we've integrated with 40 different health records. We've started working with Johns Hopkins ACG risk model to be able to identify, are DPCs cherry picking patients, or are they working with critical high risk patients? And then we've also been adding claims data across the country. So we have health record data, we have telehealth data, claims data. We're trying to get a full picture of what's happening with these populations and being able to measure those with rigorous academic methodologies.
Gotcha. So you mentioned some of the health information exchanges, because that is another segment that you work with. You mentioned Johns Hopkins in there. What are you seeing from that health information exchange? Why are they coming to KPI Ninja in the first place?
Yeah, Chris. So basically, if you look at a health information exchange at a regional or at a state level, these are not-for-profit, typically organizations, where competing, health systems and independent clinics and different post-acute care organizations, share data so that the physicians can get a longitudinal view of the patient itself. So that was the primary use case of a HIE. But if you look at what HIEs have amassed, over the last decade or two, they have like really holistic, understanding and view of a good chunk of the patients, within their state or region, or like cities, in really, really big metropolitan cities and stuff. So how that data can be used and leveraged, from a DPC is something that we're actually working, that we have started working over the last several months. So what we believe, what's happening if you look at the whole direct primary care model. So there is really good understanding of what's happening within a practice. So if a physician or a group of physicians or providers working in a practice, and if they're taking care of the patient, most of that information is documented within the electronic medical records or within the virtual communication applications and stuff. But if a patient is having an ED visit or inpatient hospitalization or going to a specialist visit, unless the patient actually communicates all of that information to the practice, that information may not reside in within the practice itself. And
Right.
if the practice has multiple employers, you may be able to get data from claims if they are self-insured. However, that's not real time. It's 3 to 6 months old, as we know. So that's where the HIEs come into play in supporting the data gap that is existing, beyond the four walls of the DPC practice, in providing the information about the patients that the physicians are and the practices are taking care of in regards to outside care that's happening, around DPC. So that's where in near real time, you can get patients who had ED visits, patients who have been hospitalized, patients who are going to these specialist visits, and that information provided in real time or near real time is really impactful, if you look at from a care coordination perspective. So that is what we are trying to close with our work in the DPC space, and also including the work that we have been doing in the health information exchange space. So we are doing a pilot here in the state of Nebraska, combining DPC and health information exchange, and we plan to leverage this across all other states in the coming years as well.
Yeah, and that's really impactful. Like you said, just want to highlight a couple of those, is that you get almost real-time feedback if somebody is outside your office, rather than that lag time of, I think you said 3 to 6 months of knowing something else is going on. I would think that would be insanely valuable. And I know that, a lot of the doctors in the DPC clinics that we work with find a lot of value in those types of numbers. So where are you seeing your most growth? Is it, like you said, working with state exchanges, or is it more of that physician-led growth on the DPC side, or otherwhere?
It is actually in both the areas, like direct primary care organizations as well as health information exchanges are the core markets that we focus, just because of the amount of opportunity that is existing, to demonstrate the impact itself. In the direct primary care space, we believe, our vision is to amplify the stories that are being shared, by a practice, by organization, by a physician, through data. That's
right.
Solely our vision, and we have been combining several different data sources, to put data behind, their stories, and also publish research and help the movement itself in the DPC space. And along those lines, in the health information exchange space, with all these different value-based programs and population health initiatives that are coming up, it is really important for us, to support the health information exchange movement and helping them move from a transactional entity to a population health entity, and supporting payers, providers, and even organizations like direct primary care organizations, to leverage the data and provide and create value within the state or within the region itself.
Right. So, I mean, it's really remarkable. You're able to work with organizations, big state level initiatives, and individual practices. So, looking at kind of individual practices or these DPC organizations, once you guys have the data and you're able to, like you said, tell a story about it, which I love telling stories. That's why we have this podcast in the first place, right? Is that your team helping people analyze that data, or how is that handled once you already have those numbers?
That is a great question, Chris. So I would expand a little bit around what we are doing, and how we even encourage practices to assess and analyze where they are in their data journey. So we have identified 4 major areas, and it's a step-by-step approach on understanding the maturity of the analytics, deployment within a DPC organization. The first step is integrations. So it is really important to have a solution that can integrate with multiple sources of data that a typical direct primary care organization interacts with. It could be a membership, database, or it could be a virtual communication. It could be electronic medical records. It could be claims. It could be patient satisfaction surveys. If you're looking at, data within each of those different data sources, then you have siloed information and you don't have a comprehensive picture on what's happening at a patient level or an employer level.
Right. So,
so it is really important, to integrate with all these data sources. That's step one.
Right. So getting everything talking together is, just to summarize there, that these systems have to be able to communicate with one another, right?
Exactly. And the data system or the analytics solution that you have should be able to integrate with all these data silos and, bring all of them together. I would call that as step one.
Okay.
And that's the foundational piece for DPC.
Right.
And step two is, yes, now you have all these different data sources and you're bringing all these different data elements. So how do we tell the stories? How do we build insights? How do we build dashboards? And we all know the power of, visualizations, the kind of impact it makes, to quickly assess, whether you're improving, you're declining in some areas, or where you have opportunities and stuff. So that's why it is really important to put all these numbers together and visualize the information. That's, step two. And every practice, every organization have different use cases, different focus areas. So, understanding what those, goals are and trying to, visualize that information and monitor, track, and identify how you're performing is going to be really key, as a step two or stage two in the analytics journey in DPC.
Sure.
And then and stage three, or step four, is, yes, now you're bringing all these different insights and all the dashboards and stuff. How do we make the data actionable? So if you do not make the data actionable, then you just have these pretty dashboards, and you're going to, look at these dashboards and you build knowledge, but if it is not actionable, then, it is not going to help you to impact the outcomes. So when I say making the data actionable, means understanding, what your goals are. For example, if you're trying to improve your outcomes around diabetic patients, so understanding, patients whose most A1C is greater than 9, whether they had a visit in the last 3 months or 6 months, and tracking, patients who did not, update their medications, for over a period of time. So there are like several different ways on, understanding and making sure that, the data is actionable. So that's stage three. And the last stage is, as Kyle was mentioning earlier, predictive analytics and risk stratification to identify and focus on those 10, 15, 20% of the patients, which would have, 80% of the impact on the overall outcomes, within the practice or an employer. So just understanding that, these are, the 4 stages on how we look at, from a DPC lens standpoint, around data and data analytics, and identifying, where the organization itself is from an analytics, maturity model itself is going to be important to, to see and to make improvements on these different stages and to make an impact and become a data-driven organization.
Absolutely. And it makes people's lives easier too. When, if you're a physician, you're able to look at some different numbers and look at the data and say, oh, okay, here's where I need to focus energy, or highlight cases of people at risk. It makes your life a lot easier because you don't have to dig through your records and take a lot of the time because it's right there. Right?
Yep, exactly.
And I love the actionable part of it because to me, that's what separates data from just having information. You're able to act upon the data, right?
That is correct.
So tell us a little bit here about how KPI Ninja is able to do all of this. How are you able to integrate with so many different systems? How are you able to analyze, visualize, and then take action on this data you're getting? What does your team look like, and how are you really positioning your company to grow in its current environment?
Yes, we do have a really strong team around direct primary care. And just to give you a little background, our work on our work in the direct primary care space, we have been working with practices, physicians in the direct primary care space over the last three plus years. And one thing, we have absolutely focused, as we build the product, as we build content, and as we do research, and as we support the movement, it is specifically designed for direct primary care. So even though we have a deep experience in the fee-for-service space, we did not carry all of that, infrastructure, product, technology, and everything, directly into direct primary care.
Mm-hmm.
But we did spend quite a bit of time understanding DPCs, interacting with tens and not hundreds of physicians and practices, and understanding their needs, and understanding their customer needs, whether it is an employer or whether it is a patient, and what they're looking for, and how do we create value. So with that mindset, with those foundational principles, we identified our vision to be, how do we amplify the stories that are being shared in the direct care community through data? So that's our vision. So with those foundational principles, so we started along the journey, those four stages that I was referring to earlier, which is integrations, building insights and dashboards, and making the data actionable and predictive and risk stratification analytics. So we started with integrations. So we have, as Kyle was mentioning, 40 plus EMR integrations, and we have more than 65, 68 integrations, whether it is membership, EMR, virtual communication, patient experience, labs, and so on. So our goal, our number one job, is to make the data interoperable. So we do the integrations, and for some of the tech stack that's being used in the DPC space, we can actually integrate in less than 2 days. The typical technology stack that is being used in the DPC space. That's our record and how fast we can integrate and stuff. So once we do the integrations, we understand, the organization's, goals, and every organization have, different goals, and whether it is, better managing the patients or making an impact on the overall cost, for an employer. So we understand those goals, we turn those goals into, from a, technical / data requirements, and help those practices, those physicians, better track this information, and provide this information in a meaningful way that would cut down the amount of time that they spend, on extracting the data, but more time is being spent by the practices in actually contacting the patients and using this information to make an impact. And then once as the process matures, we also work with the practices and organizations to write case studies and tell the stories and and share this with the broader community. So we have been doing quite a bit of background foundational work to cut down the amount of time that may be spent on non-value added activities, from a practice physician standpoint, gathering the data or, prepping the data or combining all these different data sources. And we are giving, we are automating all of those pieces and helping them, provide this information so that could be actionable, and they could, directly contact patients, and make an impact on outcomes, and, demonstrate these stories to the employers and patients and to the community as a whole.
Right. It is an amazing mission, an amazing job you guys are doing, making patient data and clinical data accessible and actually useful for the medical professionals that are out there caring for everybody. I love it. I absolutely love what you guys are doing. And obviously with Freedom HealthWorks and KPI Ninja, our fandom, extends into using you guys, using your service. And Kyle, like you said, hopefully getting some great studies out there and some cases and some awesome use examples. So this leads me to our last segment here on our show. We call this the Healthcare Americana Crystal Ball. So this is where I get to ask you, and Kyle, I'll let you go first here, but gaze into your crystal ball. Where does the industry and your organization go from here? What are you seeing in the future?
Sure. So what I've been seeing so far, direct primary care is a fast-moving space. There's a lot of activity and passion leading to tremendous growth. We're starting to see a lot of employer movement. And then recently, we've even been seeing a lot of policy and federal government activity as well around the model. So the majority of the movement originally came from very passionate physicians, taking the plunge into how they practice and how they're paid. Mm-hmm. But in my mind, they need back-end support through research and data, especially as you get into the thought of, we as a healthcare community owe it to our society to study the model, learn all its strengths and weaknesses, and then how do we implement that into the larger healthcare system as a whole. Mm-hmm. So what we're doing is trying to help them, on the back end with data and research, is help them prove the model and help them do policy advocacy, maybe go to employer groups and show the value. And then overall, ideally, we'll wrap it into health information exchanges and have just more transparency on how data is shared, how data is used, and then the value that we're able to see on the back end. Fantastic.
Vineeth, what about you?
Yeah, I share Kyle's vision and from where KPI is going, and also I would like to add to your question on where the industry is going from here. As we all know, the healthcare premiums are increasing at a 2-digit rate, right, year over year.
Right.
And if you look at from an employer perspective, and we are also an employer, and you are an employer. Healthcare insurance costs are probably in the top 3, top 5 line items when you look at our P&L statements.
Oh, easily. Yeah.
It is really important, to control the costs. Otherwise, it is going to be something, that would be unmanageable, over the next few years. So if you look at, the demand supply, what's happening, in the market, from an employer perspective, it is really important. It is getting more and more important from them, to reduce the overall costs and improve, the benefits and improve the outcomes, for their employees and their members. So that's the demand that we are seeing rapidly increasing, over the last, couple of years, and we see that, raising, quite a bit, over the next few years. And DPC is one of the interventions that employers are considering right now. And we want to, place ourselves, to support, with meaningful data that this intervention, does support and make an impact on the overall cost and improve outcomes. So broadly speaking, with the whole self-insured or with the employer space, moving and trying to find these innovative solutions to save costs, and as DPC becomes, the mainstream, we definitely want to align with the movement and support DPCs, to be the solution to reduce the overall cost and improve the outcomes and make an impact on the triple aim that we've talked about earlier. And from a technology and from integrations and from the work that we have been doing, all of that, body of work is going to be, again, completely aligned to demonstrate and to show the value of DPC and to support the overall movement that's happening right now.
Right. And I don't see a lot of growth in the future of the industry without KPI Ninja being there to help support it and really help lead it. So, gentlemen, thanks for taking time to chat with us today. Wish you the best of luck and look forward to following all your success in the future.
Thank you so much, Chris. And we really appreciate the opportunity to be on the podcast.
Absolutely. That's it for today's episode. Healthcare Americana is powered by Freedom HealthWorks, produced by Taylor Scott and iPodcast Pro. I'm Christopher Habig. Thanks for listening. Hi again, everyone. This is Chris. At Healthcare Americana, we're always on the lookout for great stories to tell in the healthcare industry. And we'd like to hear yours. Check out healthcareamericana.com and send us your ideas for episodes or if you'd like to be a guest. Thanks again for listening. Hope you enjoy it.